Good afternoon, everyone. We are kicking off our fourth full cohort webinar for the Health Information Technology Learning Collaborative, and we're super excited to be joined today by the Trailblazers Learning Collaborative as well. So we have a large audience on the line. Just a little bit about us here. I'm Anna Barnes. I'm a program manager at the Illinois Public Health Institute, and I'm joined in the room today with my colleague Antonia Lalagos. We also have Maya Abdebeki from N4a, and she's going to be leading a number of slides for us as well. So we're really excited to be co-hosting this event with you today. Just a few housekeeping items here. We plan to record the webinar, so you can come back to it if you have to hop off early or to share with your colleagues. We ask that you please mute your microphone when you're not speaking. So far, everyone's doing a great job, and we don't have any feedback, so that's great. If you do hear feedback, just check your computer line, or if you're in the conference room together, check the conference line and see if any of there might be other speakers that are on. Okay, so moving on here. The plan we have outlined for today, and a number of you will be actively presenting, which we're excited about. We have very short, we've asked a number of you to share, and we've collected questions from, if you just joined, if you can please mute your line, that would be great. So we've collected questions from the Health Information Technology group for the Trailblazers, and we've collected questions from the Trailblazers for the Health Information Technology group. So we're going to do a bit of a back and forth kind of show and tell. These presentations are really not meant to go in depth on a topic, but just to tee up ideas for conversation or further exploration, either for small group calls or future webinars. And then we're going to take, that'll be the bulk of the webinar. Then we'll take a little bit of time at the end to talk about the products or the tools that we're working on in each of these respective learning collaboratives, and then we'll wrap up from there. So I think I talked about this a little bit, but really the purpose of today is kind of just to expand your peer learning network. We have two really fabulous groups of community-based organizations and AAA and disability agency providers in this broader network. So we feel like there's a lot that you could learn from each other and wanted to bring you together this way. So we'll highlight some of the knowledge in the group, leverage each other's experiences to date, and seed topics for future conversation and learning. So I'm going to pass it now to Maya to briefly introduce the Trailblazers group.
Sure, thank you, and welcome everyone. We appreciate you all being on the webinar with us today. Just a quick background on the Trailblazers for the Health IT group is that this particular learning collaborative stems from an ACL grant that is focused on advanced business acumen skills, and it was awarded in September of 2016 with a duration of about 30 months, so we'll be coming to a close this September. And the basis of this ACL grant is to organize and conduct topically based action learning collaboratives in order to address next generation issues and create knowledge and to really capture insight through these collaboratives in order to create curriculum and products like the tools for national dissemination. This grant also builds on a lot of our work funded by the Johnny A. Hartford Foundation here at N4a. And these particular sites for the Trailblazers were actually selected for being, quote unquote, the best of the best for their advanced business acumen skills and for having successful contracting experience with integrated care entities. So this group was actually split into two self-selected working groups, which we'll talk about later. And that's the health systems group and the health plans work group. and each of them focus on developing strategies and tools for building partnership within the healthcare sector. So as you can see up here, we have a list of our Learning Collaborative members separated into our 2 work groups. Next slide.
Great, and then I'll introduce the Health Information Technology Learning Collaborative. We have 10 sites, and our group kicked off this fall. I believe it was in September. We have community-based organizations and AAAs from across the country, and our group is working on building IT systems or data system capacity for a variety of purposes. Some of those high-level goals include improving data analysis and reporting, for care coordination and care management services, for closed-loop referral, and for billing with health providers or plans. You can see on the side here on the right, oh, that's okay. We're in each of the communities in our Learning Collaborative are in various stages of implementing either a new data system, but everyone has active systems that they're already working on. It's just a matter of thinking about streamlining those systems and where the opportunities are for further investment. Here's a map of our 10 sites. And then here's a list of the groups that are participating, and we broke them down into 2 groups. But, really, there's a lot of overlap across the 2, but the first one was a little bit more focused on billing and payment with a healthcare organization, and the second one a bit more on sort of internal data integration and analysis systems. And I'll leave it at that for the work group. So we decided that just to kind of keep you on your toes a little bit, we're going to test out a new system that we are working with here called Mentimeter for polling. So we wanted to give you guys a sense of the breadth and depth of this larger audience on the phone today. So we have this poll: what state is your organization located in? So on the call, let's see what the results show us here. Okay, so we actually must have a couple communities from Massachusetts, Washington, and Indiana, and then a number of other states that are represented here: Connecticut, Oregon, Virginia, the Midwest, New Hampshire. Great. And then we have another introductory question here. Are you working more as a hub or an individual community-based organization? So let's see, it's about a 50-50 split right now. So that's great. And I think we have one more introductory question for the audience here. The size of your organization. So let's see, as people are working on completing this. Wow, so more than half of the group is quite a large agency with over 80 FTEs. We have a couple then on the smaller scale, 1 to 10, and then a few in the middle there. That's great. Okay. Perfect. So that was just to give you a little flavor of who's on the line. The way we have this set up is that the Health Information Technology group, we've identified a couple speakers from our cohort that will be responding to questions submitted by the Trailblazers. So let's see, first up we have, these are the questions that were submitted. What data elements are you collecting? What types of reports are you generating? Live stream and sound generations will be giving a short response there. And then the other question was, have you been able to bridge data systems with an MCO or health plan? And how far along are you in that process if you're not there yet? So we have age options and Maryland Living Wealth Center of Excellence. So let's see, we have a few polls here to kick off those 2 topics. So if you want to take a minute to complete that one. How many data reporting systems do you currently need to use to share or report your data?
Yeah, I'll just give you the
do it? Well, yeah. Okay. Let's see what we have here. All right. So many of you, the majority here, are using 3 or more systems, which is not at all surprising. I'm really curious about a couple of you that are currently just using one data system. Okay, and there's one more question after this. You can go to that one. Type in the names of the data systems your organization currently uses. Okay, so a number of you are using Workshop Wizard, and then there's quite a large smattering of other systems. Kind of watch as the data changes up a little bit here. Some National Council on Aging databases. Great. Okay. So I think, let's see, who do we have presenting first here? We have Livestream that will be presenting.
Hi, yeah, and it's actually going to be Paul Watkins on behalf of Livestream. So yeah, my name is Paul Watkins. I'm the co-founder for Translating Data, and we're actually contracted with Livestream to basically do analytics as a service for them. And there's quite a few components that go into that. So I'm going to try and keep this really short. Like we said earlier, it's basically a very high-level overview of how we're looking at the data and working with it. So if you could just go ahead and continue to the next slide there. Great. So basically what we realized is there's a lot of information gathered. So there's transactional data out there, right? And that's a lot of the systems that were just listed in the previous screen. So like peer replace or your state mandated system, or wherever you're basically just entering information. And it's usually coming in from multiple sources, similar to what the survey just mentioned. And if you have internal sources, there's actually external sources of data that would probably also be helpful. So what we're doing is we're consolidating all of that, cleaning it up so that you can work with it, and then applying some analysis to it so that you can actually apply it. And it's a tool that can actually be useful to you rather than just a chore. So you could continue to the next slide. So there's a few things we wanted to do to kind of standardize that process. So several of you are probably familiar with like logic models or some kind of strategic planning that you do. So what we do is we have a series of steps that we take to basically understand the program as a whole. And then we start to look at potential outcomes that drive that information. And a lot of times people are actually reporting on inputs and outputs. So it'd be like the number of people you serve, how often you visit people in the home, et cetera. But we actually define an outcome as like a behavior change or a shift in funding or policy. And then the impact would be like lowered readmission rates or got people to be more positively engaged with their healthcare. From there, we basically set up a series of evaluation tools based on that data. So each agency kind of has a unique approach to how they want to evaluate their progress. A lot of times that's around compliance measures with a funding source like your state. But what we look at is also who are you trying to work with? Who would you like to communicate to? What are the criteria they're looking for? And how does your information stack up against that? And if you have missing information, what's the additional data points that would be helpful? And then as you apply that evaluation criteria, is it actually driving you toward the intended indicators you'd like to measure? So next slide, please. And for us, basically, we try to treat the data as an ongoing process. So usually there's like a lot of information out there, and it's very confusing. It can come in very messy. It can go out very messy. So what we do is we actually consolidate it into what we consider a data lake or a data warehouse. And then from there, we use tools like Snowflake and Matillion. And there's some algorithms and some special things you can do to kind of indicate if you're on the right track with the right kind of information. And so as we go to analyze that data that we receive, we can visualize it in a tool like Tableau, right? And ultimately, you need to be able to take action on that. So what we do is review that information with our end users, right? So that they can understand, like, hey, are we on the right track? Does it make sense to you? How would you communicate this to other people internally or externally? And then from there, we adjust the data as needed, or different algorithms we use, et cetera. So if you go to the next slide real quick. So once we do that, we place the data into these different buckets that most of you are probably dealing with as community-based organizations, so that we can pull that information very quickly and we can aggregate it as a whole to get a big picture of what's going on. And then the next slide. And so what we do is we have this data maturity assessment that everybody takes, including Livestream. And this is not their assessment per se, this is just an example. But ultimately, what we want to do is create a roadmap to optimize that data. So as we understand that roadmap and we get to that outer edge, we can actually start to apply like machine learning techniques and predictive analytics based off of like the program theory and evaluation criteria. So as we identify those points of truth, we have something to build off of. But initially, you don't want to try to consume the elephant all at once. Maybe it's just trying to get access to more information so that you can validate what you're doing. So these specific data points are custom developed by each program and tried to drive towards specific outcomes related to funding sources, et cetera. So hopefully that answered the question. And I think I'm out of time. Yeah.
Yeah, thanks, Paul. You were right on time there, which is great. I think we wanted to kind of keep it moving a bit on the second presentation on the same topic here. What data elements are you collecting and what types of reports are you generating? So we're going to pass it now to Sound Generation.
Hi, this is Megan Thompson at Sound Generations. I am the data manager for Project Enhance, and I'm just going to quickly show the data elements that we capture at kind of a high level, and then what part of that we use for reporting for reimbursement for one of our evidence-based programs, Enhanced Fitness. So next slide, please. So again, at a high level, these are the categories of the data elements that we collect for Enhanced Fitness. We work with other programs too, but EF is the one that we have reimbursement processes with, so look at that. Basically, we collect information on the participants, the demographics and other contact information. That tells us who we're reaching. We collect outcomes measures. This is different by each program, but for Enhanced Fitness, we collect satisfaction and functional fitness tests. And this lets us know if participants are improving as a result of their participation. So that's key information for us. We also collect attendance data for participants. That's session level, so we know what date each participant attended the program and at what locations. That lets us know what dose of the program the participants are receiving and how long and how consistently they're attending the program. So next slide, please. Out of that set of data, we focus on the participant and attendance data. Those are the key elements that we found have been important for reporting to the healthcare systems that reimburse for their members to participate in Enhanced Fitness. So far, there's two, Kaiser Permanente of Washington and Silver and Fit. And so in both cases with those organizations, we found that they want to know that we can show them who's participating and at what rate, what dates they're attending. So those elements of the data that we're collecting anyway for our program monitoring and management are the ones that are important to report for reimbursement. And I think that was what we were primarily focusing on, but we have, oh, go ahead, next slide, thank you. We do have other reporting available. Those are more reports for program management that the affiliates that implement the programs use. So we have aggregated outcomes evaluations reports, evaluations on participant satisfaction, demographic profiles, so affiliates know who they're reaching in their communities. We have the management reports that let the classes know who to follow up for with outcomes measures, how to contact them, and so on. We also have participant-facing reports. We find that that's really important for affiliates to give the feedback back to the participants with how they're doing in the programs. And I think the next slide has some images of those sorts of reports. If you go to the next slide, please. Thank you. And so these are just snapshots of some of the types of reports that our data systems produce for giving feedback both to the programs that are implementing the programs and also to the participants. And I think that's our last slide. Oh, no, a couple more. These are the participant-facing reports that that the providers can give to the participants so they can see how they're doing in the programs and keep them motivated to attend. And I think these last slides may be more important for questions and answers, so we can probably pass over these now.
Great, thank you, Megan. You guys are staying right on time, which is wonderful. So before we move to the next question that was submitted by the Trailblazers for the HIT group, we have two more polling questions here. So this one is, does your organization share data with the Health Information Exchange or Health Information Organization or RIO? So it looks like just a few of you currently. And it really depends on if you have that kind of infrastructure at your state or regional level to leverage. Okay, that's interesting. Great. So just a couple. And then does your agency readily have access to data sent to a contracting entity's data warehouse? So are you able to get data from a provider or health plan? Okay, so a few more have access that way. That's great. Okay, wonderful. So our next presenter here will be Age Options, and they will be speaking to this question: have you been able to bridge data systems with an MCO or electronic medical records? How far along are you in that process if you're not there yet? Great. And we're going to pass it to Rob.
Hi, everybody. So you can go to the next slide, please. Just for a brief orientation, Age Options is the area agency on aging for suburban Cook County outside of the city of Chicago. And we operate the Illinois Pathways to Health network hub for CDSMP and DSMP. With the typical ACL CDSME goals to expand capacity, to deliver the workshops, and sustain the work through healthcare insurers and providers. We're also a current recipient of the ACL Nutrition Innovations Grant, and I'm going to speak briefly about the ways we've worked with data under both of these two grants. Next slide, please. So the first one is, this is kind of I guess, a low-tech way of working with healthcare providers, I guess. Our preferred model of working with healthcare providers, insurers, and hospital systems is to do panel engagements where they really identify the patients within their system who are most appropriate for our services. Through their population health approach, they pull those patients, they put them into a report to send out to us. They send it out to us through encrypted email. We receive it, and then we store it on an encrypted cloud drive. We engage the members. We do reporting on those members that we've talked to, and ones we haven't been able to reach, and then we send it back to them through encrypted email, and then they actually enter it into their EMR to demonstrate who we were able to reach or not. Next slide, please. The other one that we have is we have a closed loop referral system that we're a part of, working with two different hospital systems under our ACL nutrition grant. One is Rush Oak Park Hospital, and the other is Oak Street Health, which is a physician clinic system, a fully capitated one. We use the NowPow system, which was developed by University of Chicago Hospital System under a CMS Innovations grant. It's basically, the concept is, in general, hospital systems can do referrals to community-based services. Over time, they've added that, and that was usually like a handoff, a print-off to patients. Over time, they've enhanced it so that there can actually be two-way referrals and a closed-loop referral system. So we're using that to test the increase the referrals to nutrition programs, and then also provide them feedback on how who got services, and then get that back into the EMR. So how that looks is they do an EMR social determinant screen, and if the screen indicates there's nutrition risk, there's a referral through NowPow to Age Options. We receive that referral of the patients. We call up and engage the patients, figure out what kind of nutrition risk issues that we can address. Could be SNAP benefits enrollment, it could be congregate meals, or it could be home delivered meals. We make the referral, we follow up and make sure they get the referrals through our network of service providers, and then we close the loop through NowPow, and then it ends up back in the EMR of those two organizations. That's it for me.
Cool, thanks, Rob. That's new information for us, so that was exciting to hear.
Happy to share.
Great. So our next presenter here is Sue from Maryland.
Good afternoon, everyone. Go ahead, you can put the next slide up for me. So I know you all get tired of hearing how unique Maryland is, but once again, I'm going to just let you know we have really exciting, very unusual system in that now, as of January, both our hospitals and physicians are under a CMS single payer capitated rate. It's the total cost of care model. We were successful, the hospitals were, as of 2015 in really moving to this model and really reducing Medicare costs. And they're projected to save Medicare, you can see, $330 million over the next 5 years with this new system. The key, I think, to understanding this in terms of a AAA or an evidence-based program provider is that we become more and more important in this total cost of care model. And so the population health requirement as well as this total cost of care really allows us to become a more significant player. So I've been asked really to talk a little bit about our HIE, and if you want to go to the next slide. Yes, we're able to share data in our HIE, and we can access limited data, not a great deal from it. But I think you can see by looking at this, we are a very small fish in a very large pond. If you recognize that our HIE is dealing with 42 million data pieces weekly, very difficult to extract meaningful information or to get significantly meaningful information out through the system. It's a remarkable system. It has a lot of data in it. And they are doing a lot to personalize how docs and others can access data. But you can just see from this, just imagine the huge amount of data that's flowing through the system. So next slide. So we do certainly have some wonderful benefits. We do, in order to partner with our HIE, have an expanded participant consent form that we use with all of our participants in evidence-based programs to share that data. And we do track, again, we're able to utilize that HIE system to look at changes in healthcare utilization, hospital and ED, really based on people who've gone through evidence-based programs. So that really is the key that's wonderful for us, is to be able to submit patient panels and then they're matched to hospital utilization. So yes, we have data sharing agreements with both hospitals and with CRISP, which is our HIE. And we absolutely believe that this is critical information. We talked, I think others talked about, or had the question about accessing the EHR. We've been promised that with our local hospital for about 2 years, and we're still waiting for that kind of system. So the data sharing piece is an ongoing challenge, but we do find that the partnership with our HIA is really critical to our really being able to demonstrate the value of our programs. Next slide. So I've included, this is an example of our expanded consent form, and I can certainly share this in hard copy if people need it. Next slide. I think is, yes, our data sharing agreement that we use in order to do this. There was also the question about whether or not we're working with managed care organizations, and we do have a contract with one of our statewide Medicaid managed care organizations, but we're in the very early process of that, and so don't really have any data to speak of yet. And I will turn it over now to the next speakers. Thanks.
Thank you, Sue. That was really wonderful. I'm just kind of thinking, let's see. I think I'm just going to keep us moving. I'm tempted to go to some of the questions, but I think I'll save them for the end so that we can do equitable distribution here between each set of questions. So we're going to pass it now to the Trailblazers to present. And here are the questions from the Health Information Technology Learning Collaborative. What needed to be put in place to execute a contract in terms of staffing, data systems, then who initiated the contract or spearheaded the negotiation? Are there any examples of a redacted contract? And then next we had, what data did you agree to share and how? Per the terms of the contract, have you been able to receive health outcome data? And then lastly, what legal and or privacy security challenges were ever overcome on both sides? So I think we have a couple of maybe one poll here, yep, to kind of tee us up for the next set of presentations. What type of healthcare entity are you currently contracting with? So is there a way to zoom in a little bit on those? We have quite a variety spread here. And this question, you were able to select all that apply. So we have hospital systems, Medicaid plans actually as the biggest contractor, and then hospital systems, and of course, some combination of the above. So multiple here. It looks like the lowest one is the contracting with the primary care or physicians group. Okay, and then what services are you currently contracted for? Select all that apply. So pretty equal distribution. It looks like maybe care transitions are the largest scope of services, equally followed by case management and evidence-based programs. And then some other services as well. Great. So to respond to the question, what type of healthcare entity are you contracting with? First, we have the Indiana Association of Area Agencies on Aging. So we'll pass it to you. We'll do the slides on your behalf. So I think we have Kristen presenting. Yes. Great. Oh, now we can hear you.
Oh, can you hear me now?
Okay, now, there we go. Yep.
There we go. Okay, great. Okay, so can you go back a slide? Thank you. The Indiana Aging Alliance is a subsidiary, limited liability company subsidiary of the Indiana Association of Area Agencies on Aging. Our primary contract is with Anthem as an Indiana Medicaid managed care provider. We do not have MLTSS in the state, so this is for their regular Medicaid population. And we are doing care transitions for them. We also have some more advanced AAAs in our state that are contracted individually with local hospital clinics and physician practices. A couple of those AAAs have also been participating in the Trailblazers Learning Collaborative as part of Indiana Aging Alliance. We are also contracting with HTS Consulting for a rebranding of the Indiana Aging Alliance, and Maya had asked me to speak a little bit about that. Next slide, please. For the Medicaid, in terms of how we got in touch with the right person or people to begin contract discussions, for the Medicaid contract, a representative of the managed care organization was on one of our AAA's board of directors. And they began talking to each other about how contracting with an area agency on aging might work. So they worked on a pilot, and that was eventually expanded to the entire state through the Indiana Aging Alliance entity. And we've gone through several iterations of that scope of work at this point. For the rebranding contract, we found HDS Consulting through the Trailblazers Learning Collaborative Network. Because what we are trying to attempt as a community-based organization and area agency on aging is pretty complex when you look at it from the outside. We were interested with somebody that had both AAA and healthcare experience. And so HDS had previously contracted with another person in our network and also had a healthcare background. So we didn't really have to go through a lot of education in that regard. Next slide. So from our contracting experience with the Anthem contract, we needed to increase the flexibility in our limited liability corporation to enable additional contracting opportunities in the scope of work for Anthem. One of the things we've been disappointed in is an inability to get any kind of volume guarantee, although we continue to talk about it, outcome data, and we also need to have patience. As things change within this large MCO outside of our contract, it affects their key players. We end up with new key contacts who have different thoughts or ideas about the scope of work, and so we're constantly having to re-educate and help them understand how we can add value to their patients that they serve. And this takes time. Sometimes months, sometimes years to work within their bureaucracy. Our most recent experience was we were on hold with them in terms of looking at a new scope of work for approximately 9 months while they went through an internal reorganization that had nothing to do with our contract. So we continue to have to just stay abreast of what's happening in their organization. For the rebranding contract, so far it's been interesting just to look at how a rebranding initiative unrolls itself for me personally and for those of us who haven't been involved with rebranding before. including the research, the interviews, the competitive analysis that the contractor does, including help with visioning. Next slide, please. And we were asked about the health IT data collection and reporting system we're currently using. For the Anthem contract, that is Population Health Logistics, which is housed in one of our area agencies on aging with whom we contract for the entire network. So that's it. Thank you.
Thank you, Kristen. Next up, we have Ability 360. Take it away.
Hi, I'm assuming you can hear me.
Yep.
You can just go to the next slide. Okay, so the type of healthcare entities that we contract with. So first of all, we're a center for independent living in Phoenix, Arizona. So most of the stuff that we do is all kind of non-medical, but a whole broad range of programs and services for people with disabilities. But specifically with contracting with healthcare entities, we contract with our state Medicaid agencies, managed care organizations that have the contracts here in Arizona. And they are those 4 contractors: Mercy Care Plan, which is part of Aetna, Dignity Health, United Healthcare, Banner University, Family Care, and they're new in our state. They were just recently brought in, and Arizona and our Division of Developmental Disabilities. You can go to the next screen. So we've been doing this for a long, long time, almost 30 years, that we contract to do essentially what is personal assistance services or personal care or attendant care, but these are generally our service codes that we provide. We employ 2,000 plus PCAs across the state of Arizona, and to deliver these kinds of services. But also a note on there, we actually contract to do home modifications for the managed care companies, and also habilitation, which is similar to attendant care for the Division of Developmental Disabilities. And we do some nursing home transition services, helping folks move out of nursing homes. And you can go to the next slide. I just included this in there because this is kind of new that we're doing. We've been asked to participate in some value-based incentive contracting with the managed care organizations. That's this entire focus on, reducing hospital readmissions, and trying to keep folks healthier, and being able to focus more on prevention. But some of this kind of stuff, we've just begun piloting some of these value-based programs, and so we're kind of in that learning curve stage of this program. You can go to the next slide. Well, how do we get to the right person to do contracting? And I've been here for 19 years, and I was a board member for 9 years even before that. So embarrassingly so, I must say, we've just been doing this so long that we've had contracts for almost 30 years, essentially. So we've known the players, we've been involved with them throughout all this time. But I just would encourage you to, talk to the program administrators at the managed care companies. Definitely reach out to case managers, and that's kind of the best way to make your services known to the managed care companies, to try to get them to contract with you. And you can go to the next slide. The biggest lesson that we've learned from our contracting, I think the biggest thing we always do is we aim to fulfill community and consumer needs. We've never really tried to chase money just to chase the money. We don't think that's a very smart decision. We believe in cultivating and developing relationships. And this last thing is, I think, really important. But if your state is new to managed care, I think it's really important that you get your Medicaid agency to include community-based organization services into their RFPs, so that they are essentially mandated to contract with community-based organizations. And then the last slide, I think, current health IT data collection and reporting systems. We developed our own system in-house. We've been, it kind of evolved over the years with a database application called Q&A, and then we went to Microsoft Access. And as we got larger and larger, we put it on a SQL Server database that we developed ourselves. But we are in the process of converting all of our data systems to a home care workforce management system provider, which we're planning on putting this all into the cloud. We're interviewing, we're getting demos from 3 of these vendors, HHX Exchange, MITC, and SanData. A lot of this has to do with the implementation of the electronic visit verification requirements that are part of the 21st Century Cures Act. So we have to come in compliance next January 1st with that to have fully implemented EVV. But this will include scheduling, case management, our payroll, HR, and billing, and we're, again, looking forward to the opportunities with data collection and really kind of taking us to the next level of integrated data systems that will really improve the efficiency of our, get us into total paperless office and moving everything into essentially electronic records. I think that's it. Thank you.
Okay, thanks, Phil. We have been enjoying the presentation so far, and everyone is staying to the time. So here's another poll, just to break it up a little bit. What services are you currently contracted for?
I think we actually did this.
Oh yeah, you're right, we did. So we can skip to the next slide here. And our presentation is from Partners in Care Foundation. So Esther, we're going to hear from you.
Great. Actually, I'm going to have June Simmons, our CEO, launch us off.
Okay.
Hi. I've been enjoying your presentations and your format with your polling. It's excellent. So we're happy to share what we're learning and the endless life lessons around building contracts with delivery systems. We've been at this a long time. One of the things that we think is really important, and we don't, at least in California, see many community-based organizations there.
Next slide,
go to the next slide. Is going to the marketplace, if you will. Since we're trying to get contracts with healthcare payers, we're looking at health plans, hospitals, and physician groups. We should go where they go. We find that sales presentation is really tough because they're in there expecting us to come in like a vendor and ask them for something. So we like to go and establish ourselves as peers, as members of the healthcare leadership community. We go to their conferences like the American Health Insurance Plan Association, the National APHI, the America's Physician Groups with a Managed Care. We go to the California Health Plans Group. We go to wherever we can that we think they will be there. And we get more done by getting on the program, being presenters, and also working the breaks and the cocktail parties in the exhibit hall because we're standing there as their peers. And instead of them thinking it's a sales presentation, now we're talking about new ideas and ways that they can benefit. And out of that, we usually get at least 1 or 2 good opportunities. And then typically they will indicate an interest in talking more. And then either they'll follow up or we'll follow up. Then we have a business development team. Esther's key on it. And we have a gentleman who does our communications, helps coordinate that. and then we follow up to give them more detail on scope of work, and we can provide our contract template, and or sometimes they want to use their own. But we always start with a BAA and an NDA, a non-disclosure agreement, because we don't want them to just suck our ideas out of us and then try to do it themselves. So we want to protect our intellectual property. So then Esther can tell you, because she's very active in making these things happen. Esther, you're on.
Next slide, please. So June explained the initiation of a contract, and then there's a lot of work that's done, of course, in the middle, which is before it gets executed. Is what do we do then? And we have a team that we split up the work. Really, is the contracting and the language around the contracting. In some cases, when we offer our contract, we try to use our template. But if they come back asking for their own template, or they redline our contract, our own contracting director then takes the lead on reviewing that language. So we split up who is doing what piece. And then there's a scope of work. If there's a questions and a red line back from the potential payer on what the scope of work looks like, the operations team mainly reviews how impactful the change in the scope would be to the team, as that will be handling the work once the contract is executed. And then, of course, we always involve our VP of Finance to vet the pricing and the volume that is guaranteed or not a guaranteed volume. What that is it a one-year contract? So just the terms of it and what it does financially to us. And then we bring back our recommendations back to June, the CEO, and she really handles the negotiations back to the potential payers. So there is a lot of back and forth meetings with the payers, going over discussions on the red line, the comments, the editing. It comes back to our team. We all review, and then we meet in our business development team to discuss our findings and our recommendations. Again, it goes back to the payer. So a lot of back and forth in the review and the negotiation, but we've structured it in a way that key folks are doing the handle aspects of the contract piece. One of the other questions that I was asked, sorry, quickly back to the legal and privacy security. One question that was asked in preparing for the slide deck was, what legal and privacy security challenges have we overcome? A few years back, contracting with Blue Shield, they really set the bar and the standard for us. They were tough on us and what they require, asking for a security assessments and helping us really enhance our own security. So because we've put that in place and Blue Shield really setting the bar, no other entity has been as rigorous as them. So we haven't really come across any other potential payer asking us for so much of a privacy and security language and capacity as Blue Shield has. So we're using that as our standard normally. So now we move on to executing the contract. And I do see a little, that should be NCQA. There's a space in between the NCQ and the A. So again, it came back to the entity that really put a standard in for us was, again, Blue Shield. Blue Shield required NCQA accreditation in California, accreditation, or licensure in order to contract with agencies like ourselves to provide in community-based services, that be case management or care coordination or you name it, evidence-based programming. So in order to pay us for such services, they required either some sort of accreditation or licensing, and hence we went with the accreditation route. Back then, LTSS and CQA was not available. It was still in discussion mode, so we were accredited for complex case management, and hence we're able to contract with Blue Shield. So that was something that was required in order to execute a contract. So we make sure at least the terms of the contract are very clear in scope and volume. That is something that we have learned over the years to be very clear in what the scope would be. And as much as possible to put in a minimum volume guarantees on our part, at least, to be able to staff and cover our costs, at least at a minimum, before we execute this contract. So a minimum volume is something that we focus on in our contract before we execute. And as for data, another question that was asked from the TLC group was about the data. We don't own the data. We have the folks they refer who we see, but the outcomes and the impact of our work is what the payer has. So we do try to put language in our contract for them to share the data back, to show us how were our outcomes and our results. Are we making an impact? Are there lessons learned? Can we improve? How is this working? So then we could take this, and that data is what we use to try to sell. And we require, as Jude's mentioning here on the side, a joint operating committee meetings to share challenges, best practices, stories, and data where possible. So that is something that we require before we execute. And then we finally sign. And this is, takes months in work, if not sometimes a year or years. So, but we're trying to speed things up, so it's getting a little faster. So that's where we're at. Thank you.
Thank you. Thank you. And now we have New Opportunities Incorporated.
Hi, this is Lisa Labonte from New Opportunities Incorporated. I'm a little bit different in. Can you hear me? Okay.
Yep, you were great.
Okay. I'm a little bit different from the rest of you. I'm a community action agency and a nutrition provider within that agency. So, our situation's a little bit different. We're not working with managed care or working with the hospitals. Typically, it's care transitions model, as you could see from the slide, the services that we provide. And we're fairly new in this. We ran a successful pilot program, which resulted in a DSS, Department of Social Services grant, which is requiring us to contract with 2 hospitals. And the plan is that the Department of Social Services in Connecticut is hoping to replicate this model across the state after 3 years. So we do have a lot of oversight from DSS as a result with our contracts, and any type of contracts that we're signing, they do have to look at and approve. And on the hospital's end, they're just providing us with the referrals and the data as far as the goals of the patient, whether they were readmitted to the hospital or went back into the emergency room. And they're also providing us, with a survey on the services that were received. And like I said, we're fairly new, so we've only been, our pilot was about a year ago, but this newest grant, which is a 3-year grant, just started last October. Next slide. So currently, we don't have an electronic link between the hospitals and our agency. Referrals are called in and outcomes are reported by paper. Our nurse consultant who oversees the patients that works for us is using Penelope from Athena Health, and our agency to track social determinants of health and referrals and so forth is a customized system that we bridge with Penelope. Next slide. We're very excited, and I was happy to hear Ron from Indiana talk about the system that they have in place, because in Connecticut, the Connecticut Hospital Associations are just starting a contract with United Us, which is developing a software that will link the hospitals to the community-based organizations and provide us with that two-way communication that we're really looking for. So I'm excited about that, because I think that's really important for us to be successful. And I think that that will be rolled out probably within the next 6 months to a year. CBOs report, sorry. So right now, CBOs report to hospitals on social services that we provide to the patient. The nurse has direct contact with the referring doctor and provides information on a change of condition. but again, it's not a link to the hospital. It's done, you know, through paper. Next slide. And the hospitals in turn are giving us the readmission and the ER rate, and that's and the satisfaction with the service. So that's next slide. And that's the program that we're running. And to contract with the hospital, we had to go through similar things that were discussed prior, which is, of course, a business associate agreement, which I'm listening to some of these presenters, and I think we were just so eager to get a contract. We didn't have, you know, go over it very carefully, but a lot of it is one-sided, of course, protecting the information that the hospital is giving to us, the private information and security requirements on our end, insurance and so forth. I think as we go forward, we'll be providing more oversight on those types of contracts. And then we just have a memorandum of understanding with the hospital directly, just stating what each party is responsible for.
Great. Thank you so much, Lisa. We have one more presentation, but before that, I think this is our last poll here, which is, do you have the following legal agreements in place with your contracting entities, which Lisa just spoke to? BAAs, DSAs, MOUs, other. Okay, so a lot of business associate agreements, and then as well as DSAs and MOUs. Okay. We have our last presentation here from the Trailblazers, which is from the Elder Services of Merrimack Valley, Incorporated.
Hi, good afternoon, everyone. My name is Jennifer Raymond. I'm the Chief Strategy Officer at Elder Services of the Merrimack Valley. You can go to the next slide. And if you think of sort of north of Boston and south of New Hampshire, that's us. Just a little context, we are an area agency on aging in Massachusetts, and we have a number of contracts for case management, care transitions, behavioral health work, nutrition and home delivered meals, all with managed care plans, particularly the dual eligible plans here in Massachusetts, and also newly 11 contracts with accountable care organizations in Massachusetts, or what we actually are calling the Medicaid accountable care organizations in Massachusetts. We certainly do acknowledge that a lot of the success in contracting here has been a result of some really strong policies across the Commonwealth that underscore the value of social service and healthcare integration, and in many cases mandate that kind of integration, particularly when it comes to the work with the dual eligible population. The contract that I'm going to talk a little bit about today, however, is one that is not mandated, but is one that we certainly did negotiate and contract, and our prior success under those required mandated services certainly did help. And that's a contract with respect to evidence-based programming. We also are the statewide hub of the Massachusetts network for the delivery of evidence-based programs. If we can go to the next slide. The contract that relates to the EBPs is with, our largest contract is with one of the dual population plans, and that's Senior Whole Health. Is a contract that covers any of their members across the state, regardless of how that member gets referred into a plan, and it covers the member attending one of about 14 different evidence-based programs. When we talk about how that contract was initiated, if we can go to the next slide, just like I think the gentleman from Ability 360 mentioned, this long track record of success of quality, being able to collect and share the right data certainly did help in this new contract, which is now about almost 4 years old at this point. It was initiated by us initially going to their chief medical officer as well as their CEO and saying, gosh, you know, we've been collecting data over the last year about your members who are participating in chronic disease or falls or depression management programs. And we have some really interesting data to show, we think, with respect to changes that folks make and increased activation levels. So this was a contract that was not based on health utilization or anything other than patient-reported outcomes and changes in activation. So that meant that some of the data sharing from the beginning was not as intense as we might want to see it in cases where we're looking at stronger outcomes in terms of utilization. The sort of biggest lesson learned that we have, and we can go to the next slide, that we've learned from this contract really focused on volume, which I know has been something that a number of folks have talked about as well. We did not get a minimum volume guarantee in this contract, and being really transparent, and frankly, we didn't even think of looking for a minimum volume guarantee. We were just one of those people that was very happy to have a new contract to cover something like the evidence-based programs as opposed to case management or care transitions. We did, however, in the contract build in what we call a collaborative quality improvement team, and that is very similar to what others have described as a joint operating committee, except the primary focus of this team is to look at quality improvement initiatives with respect to the process. And that's the place where the volume issue came into place. So while we didn't have a minimum volume, we had a commitment to everyone that meaningful volume was an indicator of quality, and we spent a lot of time with the staff and the leadership at Senior Whole Health trying to come up with what you see in front of you, which is a wide variety of different streams in which individuals can come into the program, and that via a referral that generates a billing opportunity. So the primary way that we found the referrals to come in was to have a agreement with the duals plan with Senior Whole Health that they would provide us with bi-monthly or quarterly internal registries of their members or their patients who were at risk for diabetes, who were at risk for falls, who were high utilization users in terms of chronic disease, and that those people we would be able to do directed outreach. So that required us to do a whole new level of business associates agreements and privacy agreements and HIPAA agreements once we decided that they were going to be sharing at least that basic level of data with respect to who their patients were and what their chronic conditions were. So I'm going to go ahead and stop there because I think I've used more than my 4 minutes, but I'm certainly happy, next slide, to reconnect with anyone after this webinar if you have any questions or concerns.
Thank you, Jennifer. And thanks to all the presenters that took time to prepare questions in advance here. We really appreciate that. So I think we're going to pause, and we did have a couple questions that came in through the chat. Speakers, if you can please be brief in your response and responding to these questions, that would be appreciated. And might have to cut off the discussion so we have a little bit of time here to talk about the tools that we're developing in each Learning Collaborative. And of course, if there are further questions that come in, we're more than happy to direct those to the speakers for follow-up after the webinar. So I know one of the questions that came in was from Oregon to Maryland, I believe. And Lavinia, you can correct me if I'm not directing it to the right community. But the question was, what nutrition risk or test are you using?
I'm sorry, what What risk?
Can
you repeat the question again?
What nutrition risk test are you using?
Okay, when we're doing a nutrition, we're using actually a couple of things, but we're using a screen too in our workshop that we do in the community. We are using the food insecurity and the MLSS in partnership with the hospital.
Okay, thank you, Sue. And then this next question I think actually could be directed to a number of you that spoke about referrals and closed loop referrals. So the question was from Livestream, and I thought either maybe Age Options could respond, or Jennifer, who just spoke here with Elder Valley. So the question is, what social determinant of health screening tools are you using? Were those developed internally or from an external organization? And how is the tool selected? So maybe, Rob, if you can talk a little bit about any screening tools you're using that connect to NowPow, and then if anyone else wants to chime in on that, that would be great.
Sure, happy to do my best on this one. So this isn't a program that I'm directly working with, but I do know that the Rush University Medical Center created their own chose the social determinant screening that they're using. They've been using it for a while to make a number of referrals. So I can ask if I can share any details, and I think Oak Street Health has a different version that they've been using. So it's 2 different versions, and they might not be shareable, but I can check.
Okay, and any of the other speakers want to jump in about the screening tools that you're using?
So this is Sue. We're transitioning to the codes, the CPT codes provided by CMS for social determinants of health. One of the key pieces to this, I think, is that our HIE was just recently in front of Grand Rounds with my boss from Living Well Center of Excellence at CMS at their Care Transitions Conference. And he indicated that 2 years ago, nobody even knew what social determinants were. And now that's all anybody talks about. So there's huge activity and action around figuring out exactly what to document. But Medicare does have CPT codes.
Thanks, Sue. Did anyone else want to chime in from the Trailblazers group? Okay, we have one other question then, which is for Ability 360. If you can talk a little bit more about your business requirements as you were searching for a health IT system, and then if you would be willing to share those with the larger group.
Sure. Well, we needed a system that was going to kind of replace our case management system, which, like I said earlier, was, you know, it resides on SQL Server database, and we're basically drowning in paper, number one, because a lot of the timesheets and authorization data, it all comes in paper. So our predominant requirement was to be able to do all of that electronically. And of course, electronic visit verification, that system is, that ultimately does achieve that for us by, making it time reporting for home care workers will all be electronic now through a phone application or the telephone telephony where people will report their time. So I think that was and then also the scheduling of being able to schedule workers, the home care workers in the home, scheduling home visits, being able to track compliance documentation. So those are the primary business requirements, I guess, we were looking at. But then we also wanted to integrate with our payroll and our billing, and also our HR, because our HR system was pretty lacking as well. So generally, I think that's pretty much what we required. And many of the systems out there today in the workforce management arena, and certainly the three that we identified that we got bids on and demonstrations of, they were pretty strong in all of those areas for the most part, although some of them outsource payroll to some sort of separate payroll IT provider, whether it's an ADP or a Paychex or something like that. Some of them want to outsource billing to the company that they liked for billing, for instance. So that was, we had to deal with that too. And we really, one of the big things for us was we wanted to maintain as much control over our payroll and our billing as possible. So we were not interested in using an ADP for payroll, because then you kind of lose control of it. And there's so much, we're talking $40+ million a year, where we didn't want to lose any control over that. So anyway,
okay.
Hopefully that answers the question.
Thank you. And if you have any documentation of that that describes kind of those requirements, that would be, if you wouldn't mind passing that along, that would be greatly appreciated.
Sure.
So we're going to spend the last few minutes here. Maya from N4A is going to talk about the tools that the Trailblazers group is working on. Our Health Information Technology group we haven't been going as long as you guys, so we're just kind of starting to think about our tools. So we'll briefly share that and then have some closing remarks from N4A. So Maya, we're passing it to you.
Sure, and I actually have the Health Systems co-chair, Laura Davey from the University of New Hampshire Center for Aging and Community Living, going to talk about our tools, and then I believe Sandy Adkins is going to be presenting on some of the health plan surveys. So I will turn it over to Laura.
Hi, thank you, Maya. Yeah, so our work group, N4A, brought forward an opportunity for the Health Systems Work Group to test and refine some tools developed by Collaborative Consulting. And Collaborative Consulting is a national consulting group really working on this intersection between the medical and social integration. So Collaborative Consulting did design the tools to provide strategies for CBOs to develop cross-sector partnerships with healthcare organizations. And I think the organizations in our work group felt fortunate to have access to the tools in the early on, this kind of sneak preview. I'll probably mention it at the end, but these tools will become available after the final testing and as part of the an outcome of the Trailblazers Learning Collaborative. So we're really thankful for N4A and Collaborative Consulting. Collaborative Consulting was trying to provide some structure and guidance for really organizational transformation, including strategic, cultural, and operational changes. And these changes are really needed to advance, our business capacity and our sustainability. And of course, as we all know, this is a huge time and resource commitment, and a lot of new skill development and capacity development for some of our smaller organizations. I was struck by how many FTEs many of the folks on the call have, and when we're thinking about some of the smaller community-based organizations and developing their capacity, it is really transformational for them in their culture. So Collaborative Consulting has developed 7 tools overall, but while we have about 9 organizations in our health system subcommittee, we couldn't take on all 7, nor did Collaborative Consulting have the capacity to help us test all 7. So what Collaborative Consulting did was interviewed each of the organizations in the Health Systems Work Group, asked us to kind of dig in a little bit so that we could narrow down to 4 tools. And they asked questions around primary challenges in partnership development, what ways organizations are seeking to improve their partnerships, what types of tools and resources would assist us in these efforts, did we think? And we had already had a brief summary of what all of the seven tools were. And then based on those interviews, we did, as I said, got down to 4 tools to test drive, and I'll review those shortly. So over the course of a few months, our work group members took those tools back to their own organizations and used them out in the field. And through that process, we're able to provide clarity and value, that feedback back to collaborative consulting, so that they could refine these based on the lived experiences and using these tools out in the field. If you can go to the next slide, this whole project for collaborative consulting is part of their partnership readiness process, which is kind of outlined on this slide. And that is to emphasize that the most effective partnerships are those that are carefully considered and address the needs for all parties involved, including the healthcare organizations, the CBOs, and the community to be served. I think one of the things that I keep hearing reiterated, and we try to reiterate with our community-based organizations, is you really have to understand the healthcare organization's needs much more than you need to understand your own, I think, and especially, I think we all come from the community and understanding their needs. And I think the other key thing around this piece was, and the tools and the readiness process, was to really think about the communication between staff, to really dig in and consider the detailed questions about the various operating elements of the agency, and really highlighting the area of need in terms of the partnership ready. Each tool has many tabs, and I think that was kind of the shocking thing when we first opened them up and said, oh gosh, I got to go through these 7 tabs, but I know the community-based organization in New Hampshire that took it on saw such real value. So I'm gonna keep moving along to the next slide. I'm gonna briefly do an overview of the 4 tools the work group assessed. So the external assessment, and this tool guides an organization through the process of conducting research on a local and healthcare market to identify and understand the potential healthcare partners and the corresponding partnership opportunities. And I'm just going to also apologize in advance. While I'm in my office, there might be some background noise, and my microphone always picks up background noise more than it even picks up my voice for some reason. The tool explores identifying other organizations to assess and market-wide activity. It looks at investigating on an individual organization, considering additional avenues of research that need to be done, and conducting analysis of the information gathered from the local market, and use that to identify potential partners and opportunities in the market. And then finally, develop a process to review and update the external assessment information gathered and synthesized on a continual basis. So that's the external assessment tool. If we go to the next slide, we have the competitor analysis tool, which guides an organization through the process of assessing a local market to identify current and emerging competition that will influence partnership opportunities. This tool specifically explores identifying existing competitors in the market and potentially emerging competitors. It gathers gathering available information on each of the competitors identified, conducting an analysis using the information gathered, evaluating how the results of the analysis might impact your partnership strategy and efforts, and developing a process for review and update of the competitor analysis on a continual basis. The third tool in the next slide is the opportunity assessment, which was really looking at considering internal and external factors to identify and prioritize potential partnership opportunities and the service models to offer through that partnership. So internal factors that may influence the identification and prioritization of opportunities, some of the external factors that may influence the identification, again, the identification and prioritization. potential opportunities for partnerships that you might not have really thought about before or considered. So it's a tool that kind of hopefully opens up the landscape of what those partnerships might be. And then also really prioritizing based on the criteria for market demand and that internal alignment and potential. The last tool I think that we took on was the tool around building the business case, or building the case, which guides an organization through the compelling business case for partnerships. Pieces like gathering and determining key details for the proposed partnership and service offering to inform the development of the case, exploring the potential impact your service may have on the variables, and summarizing the findings of the previous steps to prepare to communicate that for the communication of the value and the value proposition. So those were kind of the 4 that we took on, and like I said, we're very grateful for the process, and I'll leave it at that because I know we're running out of time.
Great. Are we passing it then to the next speaker? Okay, great. The health plans work group. So if you can just take a short couple minutes here, that would be great. Sorry that we're running short on time.
This is Sandy Atkins. Can you hear me okay?
Yep, we can hear you great.
Excellent. Whoopsie, I just minimized the screen. Okay, I'm going to try to rip through this. So we were a smaller work group and a pretty equal in terms of how far along the path to contracting we were. And initially we talked about what are our biggest frustrations. Volume was one, but we didn't have a lot of answers for that one. And then data and metrics was our other big one. And we thought, well, we can do something about that. So we decided to start with satisfaction, patient experience, and outcome surveys because, yes, occasionally we're able to achieve some degree of data sharing, but the majority of our contracts, I would say probably 90%, there really is nothing. We just do the work, and the only feedback we get is that they keep renewing the contract, so it can't be too bad. And that doesn't really help us, and it doesn't help move our, I'm going to call us an industry, along in our ability to present a value proposition. So what we did was we decided that we'll just do patient self-report types of data collection so that we can provide the data rather than asking others to give us data. So in our work group, we started by collecting all the surveys we were using. We started with an LTSS, basically a care manager feedback satisfaction survey tool. And then we went to the outside world, looked for other measures, and it turned out that after we were a little bit down the road, that CMS came out with a CAPS survey version for LTSS, so we felt that we needed to adopt those to the extent possible because our healthcare partners recognize at least the word CAPS, and so we wanted to use evidence-based measures to the extent we could and things that are recognized by the people we're trying to convince. Then we just put together what do all these instruments have in common. We eliminated what we thought were the least crucial questions, refined the question order, the wording and the answer sets, engaging Scripps Institute at Washington University, I believe that's the correct one, piloted, revised, and then we rolled out. So this is now available to others, and we would like to encourage everybody to use it. We can send out a hard copy, we can send a testing link, and then we can send a use it link. Next slide. So the idea was that we were going to have the ability to use the same survey for our internal use, which would be to compare case managers, care managers, whatever, coaches, whatever we want to talk about. We wanted to be able to use it to benchmark each other so we know how we're doing with regard to our colleagues, and then we wanted to build a business case and share the information externally. So this view is what it looks like to take the data and compare inside our organization what different case managers are doing. And you can see that out of 5, all of the scores are really quite high, but as we know, older adults tend to grade everybody positive. So it just gives us a way to say, okay, Richard and whoever was between Maria and Manuel aren't the best, and the people that are close to 5 are the best. Let's set up mentoring or something. Next slide. I see that we're already over time, sorry. This shows benchmarking. So we've got 2 agencies, and giving credit, one site had 195 records, the other had only 10. But you can see that you can differentiate how many people answered the questions in the most positive way. So we're hoping these tools allow us to do that. Next slide. And then we're also now finalizing our care transitions, outcomes, and patient experience. Again, it's asking people about their utilization, their behavior change, their medications, things like that, as well as satisfaction with a coach or the program. And then we have derived out of what we are and a lot of others are doing in care transitions and trying to get a product descriptions that people can buy into, so that if we're negotiating, like Indiana was negotiating with Anthem for a national contract, you know that you're going to get adoption of that contract if we all have a common scope of work that we're already ready to do. So the idea was that for national contracts, we should have a standard product description, and we have that for care transitions, and we'll be working on more. I think that's the end. Next slide.
Great.
Yep.
Thank you, Sandy. Okay, so we're going to wrap up here, and I know we already presented the data system vetting guide that we're sort of working on as a part of our learning collaborative. We can go into these at a later date, and they're available here, linked in the Google Drive. We wanted to just mention the online community as a space to continue the discussion, and then we also posted this new report from Siren that looks at care coordination platforms and goes a little more in depth around social determinant screenings and tools for those generating those closed loop referrals. So I'm going to pass it now to Maya for a few closing remarks for N4A, and thanks everyone for staying on the line a little bit past the time.
Yeah, just very briefly on behalf of N4A, I want to thank you all for joining us for what we hope was an interactive opportunity to share your experiences in the Learning Collaborative and highlight some of the work that you all have been doing. And we really appreciate all the time you spent with us and your willingness to collaborate with one another virtually. The products have actually generated a lot of interest, not just at the recent ASA conference, but also with ACL. So it's something we're really looking forward to finalizing at the end of the Learning Collaboratives and be able to share with the broader network. As Anna mentioned many times before, we do encourage you all to reach out to one another after the webinar if there are particular sites you want to follow up with. She also mentioned the all-in online community where we have a private N4A group that you all can communicate with one another on. And lastly, N4A wants to thank the team at IPHI, that's Anna, Antonia, Peter, and Laurie, for not only having this really great idea of bringing the 2 groups together, but for organizing this joint effort and for your continued role as the project leads of the Health IT Learning Collaborative. So thank you to IPHI and to everyone who presented today. We appreciate you all being on the call. And that's it.
Thank you, Maya. Yes, thanks again, everyone, for presenting.
Yeah.
Take care. Bye-bye.
Take care.